Welcome to This Week in Pediatrics. This week we're covering 10 notable papers spanning infectious disease prevention and treatment, neonatal and developmental care, and a cluster of studies that help us decide when to intervene and when to hold back. Let's dive in. We'll start with respiratory infections, where two papers together sketch out the modern playbook. In Pediatrics, Huang and colleagues report a multi-center, age and season-matched case control study of nearly 1,500 children with laboratory-confirmed influenza, seen as outpatients across 3 seasons, from 2020 to 2023, comparing 354 children later hospitalized or dead from influenza, with more than 1,100 matched non-hospitalized controls. Antiviral therapy started within 48 hours of symptom onset, was associated with an 81% lower risk of subsequent hospitalization, and the protection was essentially identical in children 5 years and younger, as in older children. This is observational data, so treatment-seeking behavior and unmeasured severity could bias the estimate, but the authors report E-values around 10, meaning an unmeasured confounder would have to be implausibly strong to explain the result away. The practical message is unglamorous and important. When a child presents inside the 48-hour window with influenza, prescribe promptly rather than waiting to see how things evolve. On the prevention side, Acta Pediatrica carries a concise review from Heinonen and Vartiainen on the new era of respiratory syncytial virus immunoprophylaxis. 3 products have been approved since 2022. The long-acting monoclonal antibodies nirsevimab and clesrovimab, and a maternal vaccine. Across pivotal trials, efficacy ranged from roughly half to about 3/4 against medically attended lower respiratory tract infection, and from about 55% up to 91% against respiratory syncytial virus hospitalization, with the variation driven by product and length of follow-up. Post-licensure real-world data have been similar or better, and tolerability has been reassuring. Alongside these, Pediatrics revisits varicella in its state-of-the-art review series, a disease many trainees have never seen, now resurfacing as vaccine hesitancy rises. Naurecka's Lee and colleagues focus as much on the conversation as on the clinical management, how to make the case for vaccination, and how to recognize, treat, and contain varicella zoster virus when it appears. Our second theme is the neonatal and early developmental period, where 2 papers ask what actually changes outcomes. In the European Journal of Pediatrics, Omaregi and colleagues report a 13-year single-center cohort of 581 infants born before 29 weeks, of whom about 86% received routine probiotics, and around 14% did not. In-hospital mortality was under 5% in probiotic-exposed infants, versus close to 14% in unexposed infants, and after adjustment for gestational age, birth weight, sex, antenatal steroids, and calendar year, probiotic exposure was associated with roughly a 70% lower odds of death, a finding that held up under propensity score overlap weighting. Importantly, there was no clear association with severe necrotizing enterocolitis requiring surgery or transfer, nor with culture-positive late-onset sepsis, which is the opposite of the pattern most randomized trials have emphasized. With only 79 unexposed infants spread across a period in which 2 different products were used sequentially, and much else in neonatal care changed, this is hypothesis-generating rather than confirmatory. Complementing that, the Journal of Pediatrics publishes Dusing and colleagues' 3-arm trial of the supporting play exploration and early development intervention, or SPEEDY, in 83 infants born very preterm at a mean of 26.5 weeks. Infants were randomized to early SPEEDY starting in the neonatal intensive care unit, late SPEEDY starting 15 weeks later, or usual care. Pooling both SPEEDY arms, there was no difference from usual care. That is the headline, and it should be stated plainly. But infants who started in the intensive care unit had significantly better cognitive scores than those who started later, and, after adjusting for baseline motor skills, better gross motor scores through 24 months, with a measurable change in parent-child dyadic interaction offering a plausible mechanism. So the intervention as a whole did not beat usual care, but timing mattered within it. Delaying by 3 months appeared to erode the benefit. In a trial of this size, that comparison is fragile, and it needs replication before we reorganize therapy services around it. Our third theme is restraint. 3 papers where the honest answer is to do less, or to select more carefully. In the European Journal of Pediatrics, Cooley and colleagues reviewed 5 randomized trials, nearly 1,300 children with a mean age of 6, comparing adenotonsillectomy with watchful waiting for obstructive sleep apnea. Spontaneous resolution occurred in between 44 and 55% of children managed expectantly, versus 57 to 79% after surgery. Surgery reduced the apnea-hypopnea index more in 4 of 5 trials, but the between-group differences were modest, and the most consistent surgical advantage was in symptom scores rather than polysomnography. Their conclusion is that watchful waiting for several months is defensible in young, non-obese children with mild disease, with shared decision-making and genuine follow-up, while moderate to severe obstructive sleep apnea still warrants surgery. The Lancet Child and Adolescent Health reports the NIT trial, a Phase 3 double-blind placebo-controlled study of erythrocyte-encapsulated dexamethasone sodium phosphate in ataxia-telangiectasia, conducted at 20 sites across 9 countries. Russo and colleagues randomized 105 children to 6 intravenous doses or placebo. Among those aged 6 to 9 years, the primary endpoint, change in the rescored modified ataxia rating scale at 6 months, was not met, with a least squares mean difference of about 1 1/3 points favoring treatment, but a confidence interval crossing 0 and a p-value of 0.085. Safety was good, with no treatment-related serious adverse events and no adverse signal for growth, bone mineral density, or endocrine function. After 2 decades of off-label corticosteroid use in this disease, this is a negative trial, and families should be counseled accordingly. The same theme of hard limits appears in a multi-center French retrospective analysis, also in the European Journal of Pediatrics, of extracorporeal cardiopulmonary resuscitation for pediatric out-of-hospital refractory cardiac arrest. Of 250 calls, 184 met the definition of refractory arrest, 33 met program criteria, 17 reached the intensive care unit in time, and 13 were cannulated. Median low-flow time was 25 minutes, and the median interval from arrest to extracorporeal support was 82 minutes. 1 of 17 patients survived, and 4 progressed to brain death. Stark and colleagues have since restricted indications in their network to selected etiologies, a sobering counterweight to the in-hospital extracorporeal literature. 2 papers round out the week. In the European Journal of Pediatrics, Veron and colleagues reviewed 254 children with Kawasaki disease over 20 years and found extra criteria manifestations, organ involvement beyond the 5 principal criteria, in about 30%, most often gastrointestinal. These children had higher C-reactive protein, more hypoalbuminemia, lower sodium and longer hospital stays, and female sex and higher C-reactive protein were independently associated with the phenotype. Crucially, coronary involvement, immunoglobulin resistance, and coronary outcomes at follow-up were no different. So these presentations are a diagnostic pitfall that delays recognition in a subset, not an independent coronary risk marker. And in pediatrics, a policy statement from O'Leary and colleagues on the school nurse's role notes that the 2024 National School Nurse Workforce Study found only about 2/3 of schools have access to a full-time nurse, with disparities by school type, geography, and socioeconomic status, a concrete advocacy target for pediatricians managing chronic disease, mental health, and immunization catch-up. If you only have time for one paper this week, make it the Influenza Antiviral Study in Pediatrics. It addresses a decision you make dozens of times each winter, and the effect size is large enough to change your threshold for prescribing within the first 48 hours. Here are the key takeaways from this week in pediatrics. First, treat influenza early in outpatients. Antiviral therapy within 48 hours was associated with an 81% lower hospitalization risk across all ages studied. Second, the respiratory syncytial virus toolkit now genuinely works, with efficacy against hospitalization reaching as high as 91%, and varicella is worth revisiting as vaccine coverage slips. Third, encapsulated dexamethasone did not improve neurological scores in ataxia-telangiectasia. That trial was negative, though safe. Fourth, watchful waiting is reasonable in young, non-obese children with mild obstructive sleep apnea, given resolution rates approaching half without surgery. And fifth, in preterm infants, Engaging parents in developmental intervention appears to work best when it starts in the intensive care unit, though the pooled intervention did not beat usual care. That's your roundup for this week in pediatrics. The full transcript and references are available on the episode page in your Audio Scholar library. This is an AI-curated summary. For clinical decisions, always consult primary sources and current guidelines. See you next week. If this weekly briefing is useful, follow the show in your podcast app so new episodes arrive automatically. And a quick rating on Apple Podcasts or Spotify helps other physicians discover the show. This is an automated summary generated by artificial intelligence, which can make mistakes. Always review the original source materials.